Good afternoon, everyone. Thanks for being here. It is 11:57 Eastern here, so we'll give it a few more minutes, let some other people jump in here. We'll get started. Hello, everyone. We're going to go ahead and get started. So welcome to our Lunch and Learn. Today's topic is cardiac arrhythmias with a focus on documentation that supports accurate and complete risk adjustment. And just a little about me. My name is Jolene Hansick, and I'm a nurse practitioner and a certified risk adjustment coder. My background is nearly 20 years, mainly emergency medicine and some primary care, and I've been doing risk adjustment with Vatica for 4 years. This presentation is a collaboration with our Senior VP of Clinical and Quality, Dr. Jacob Utash. Dr. Utash is a family medicine physician and a certified risk adjustment coder. So for today's agenda, We'll go through the Brady and tachyarrhythmias and focus on some of the more common arrhythmias that risk adjust that we see in primary care. So that's complete heart block, sick sinus syndrome, atrial fibrillation, and ventricular tachycardia. We'll walk through documentation related to coding, review a case study, and finish with some practical documentation tips. And then we'll wrap it up with live question and answer sessions. So put your questions in the chat at any time. And just to get started, this is why coding matters to us as providers. ICD-10 codes, they translate our clinical diagnoses into standardized data. And that data is used for many things. You've got medical research, quality reporting, public health surveillance, disease tracking, and determining medical necessity, just to name a few. ICD-10 codes, they're also used to create a risk adjustment score that reflects the complexity of a patient's health status, and that helps determine funding. So if our coding isn't accurate and complete, then we're going to risk not having the resources needed to care for our patients. And risk adjustment relies entirely on our accurate provider documentation to drive this process. And the challenge is that most of us were never formally taught coding, and clinical documentation doesn't always align with coding requirements. So Knowledge and Learn sessions are designed to help bridge that gap between what we see in practice and how to apply coding principles to our documentation. Now, when we talk about arrhythmias, it can mean many different things. But a simple definition is an arrhythmia is any heart rhythm that's not normal sinus rhythm. So a quick review of NSR. It originates from the sinus node in the upper portion of the right atrium. The heart rate is a normal rate, generally between 60 and 100 beats per minute. The P waves and PR intervals are normal on the EKG. AV conduction is normal, so a QRS follows every P wave, and the rhythm's regular. So an arrhythmia is any disturbance in the rate, rhythm, or conduction of the heart's electrical impulses, and we're going to talk about two different types. When the heart rate goes too slow, this is a bradyarrhythmia, and the other is when it goes too fast, the tachyarrhythmias. Now, this is not meant to be an EKG interpretation lesson. You already know this. We're just going to walk through the arrhythmia classifications to organize how we talk through diagnoses and documentation. So let's go through an approach to the bradyarrhythmias. The heart rate's less than 60, and some prefer less than 50. And one of the first things you do is get an EKG because it'll tell you if it's a sinus brady or an AV block. And when you look at the EKG, you have to ask three questions. Is this sinus rhythm? Next, is there a QRS complex after every P wave? Is the PR interval normal, meaning the distance from the beginning of the P wave to the beginning of the QRS complex is between 120 to 200 milliseconds? And in this case, it's normal, so the patient has sinus bradycardia. Now, if the PR interval is abnormal or they drop a QRS complex, then it's an AV block, and we just have to decide what type of AV block. If the PR interval is prolonged, meaning greater than 200 milliseconds or greater than one big box, then it's an AV. And if there is a QRS complex for every P wave, we're looking at first degree AV block. Now, if the PR interval is getting longer and longer, and then the QRS drops, that's a second degree Mobitz 1. I'm sure you've heard if the PR interval gets longer and longer and then you drop, that's a Winky Bach. If the PR interval is constant, but the QRS complex randomly drops, then that's a second degree Mobitz 2. And lastly, if you see a bunch of P waves beating at their own rate and no real relationship to the QRS complexes, that's complete atrioventricular disassociation. And that's a third degree AV block, and it's the only bradyarrhythmia that we covered that is an HCC that risk adjusts. So we have I-44-2 atrioventricular block complete. And one thing to note is that it goes by a few different names that all map to the same code. You may see complete heart block, CHB, or third-degree block. And I also have I49-5 sinus syndrome here. So this is a problem with the sinoatrial node, and it can make the heart beat too fast, too slow, or a mixture of both. So it's also called tachybrady syndrome. And other terms are SSS and sinus node dysfunction. Treatment for both of these conditions may be a permanent pacemaker for a slow heart rate that causes symptoms, or medicine for antiarrhythmias like the atrial fibrillation that can lead to tachybrady syndrome. And so there's a coding clinic guideline that tells us that if an electronic device is present, but the underlying rhythm is still there, then we code it as an active medical condition. So if the patient has a complete heart block, status post pacemaker, we're just mechanically overriding it. That underlying rhythm is still there. The condition is still being managed and monitored, so it is a reportable chronic condition. One thing you can do is ask yourself, if the patient were to stop the medication or if the pacemaker were removed, would they probably have an exacerbation? And if the answer is yes, then the condition is considered active and should be documented. And this is a coding clinic reference that explains that it's appropriate to code the arrhythmia because the device is controlling the heart rate, but it doesn't cure the underlying condition. Okay, the next topic is the tachyarrhythmias. Your patient heart rate is greater than 100 beats per minute, so you get an EKG and you look at the QRS complexes. Do they look wide or narrow? If the QRS duration is less than 120 milliseconds, which is less than 3 little boxes, it's a narrow tachycardia. And if the QRS duration is greater than 120 milliseconds, then it's a wide tachycardia. The next question is whether the rhythm is regular or irregular. So look at the R to R interval, and if the distance between each R to R interval is the same all the way down the strip, then it's regular, and if not, it's irregular. So if we have a narrow tachycardia with a regular rhythm, that gives me 3 differentials: sinus tachycardia, paroxysmal supraventricular tachycardia, or SVT, and 2-to-1 atrial flutter. So let's quickly go through each. With sinus tachycardia, the P wave is upright in lead 2 and inverted in AVR. Every P wave is followed by QRS complex. That's sinus tachycardia. And if I look at the rhythm and I see no P wave, then I'm thinking it could be a paroxysmal supraventricular tachycardia, or PSVT. Oftentimes the heart rate, if it's very fast, it can be difficult to see the P wave. You might use something like a vagal maneuver or medicine to slow things down and stretch it out a bit. If it's regular, narrow complex tachycardia, sudden start and stop, and no obvious P wave, think PSVT, most often AV nodal reentry. So the next one is atrial flutter. You're looking for regular flutter waves, and a common AV conduction rate is 2-to-1 atrial flutter, meaning every other impulse goes through. So the atrial rate's around 300 and ventricular rate is about 150. And here are the ICD-10 codes. Atrial flutter is classified as typical or atypical. In typical atrial flutter, the circuit's usually counterclockwise rotation around the tricuspid valve, and it involves the CTI. And atypical atrial flutter does not involve the CTI. In the term paroxysmal, it blankets the I-47 codes. So you use I-4710 for PSVT unspecified, and I-4719 is other PSVT. And when you see the word other in coding, you have to tell us what the other is. Use this when you document a more specific type of PSVT, like AV nodal reentry. And one other note is that atrial flutter is a V28 HCC, and PSVT is an RX HCC. So now if the patient has a narrow QRS, but the R to R interval is irregular, meaning the intervals aren't the same throughout, then this is a narrow irregular tachycardia, and that gives me two main differentials, atrial fibrillation and multifocal atrial tachycardia. And atrial fibrillation is the most commonly treated cardiac arrhythmias we see in primary care. You see these fibrillatory waves, no distinct P wave, and it's generally associated with an irregular ventricular rhythm. The other narrow tachycardia is multifocal atrial tachycardia. And if you zoom in on the rhythm, you're going to see three polymorphical different P waves. This is very suggestive of MAT. There isn't a specific code for this. It's an RxHCC, and you would just use I-4710 for the other supraventricular tachycardia, and you describe the rhythm in your documentation. So let's look at documentation for atrial fibrillation, or AF. The classification of AF was revised in the 2023 ACC AHA guidelines for the diagnosis and management of atrial fibrillation. It recognizes the disease on a continuum, and it gives strategies for managing each stage. So stage 1 are those at risk for AFib. Stage 2 is pre-AFib, when there's structural or electrical findings that predispose a patient to AFib. And stage 3 is when we actually diagnose it, and there's substages. 3A is paroxysmal AF. It's intermittent, and it ends in 7 days or less. You use code I480 for paroxysmal atrial fibrillation. Stage 3B is persistent AF. That's continuous for over 7 days, and it often requires intervention. And code I4819 is for persistent atrial fibrillation. Stage 3C is long-standing persistent AF. That's continuous for over 12 months, and we have I4811 for this. 3D is when there's successful ablation. So when percutaneous or surgical intervention eliminates the AFib. And this one's not so straightforward. A successful ablation doesn't automatically mean no AFib diagnosis. If the atrial fibrillation is still clinically relevant, it's being monitored, and it's being treated with an anticoagulant or an antiarrhythmic medication, then it is still an active medical condition. And there's not a specific code for this. You would just use the code that best describes it. And then finally, stage 4 is permanent AFib, and this is used when the patient and the clinician make that joint decision to stop any attempts to control the rhythm. And the code for this is I4821, permanent atrial fibrillation. So now we go to the other side of the algorithm. If the QRS complex is greater than 120 milliseconds, then we're dealing with wide tachycardias. And the next question is whether the R to R interval is regular or irregular. If it's regular, there's technically two differentials, but we're really focused on one, and that's ventricular tachycardia. And you'll see a wide QRS complex with very similar morphology. When we see a wide regular tachycardia, we assume it's ventricular tachycardia until proven otherwise. There is the possibility of a PSVT with aberrancy. And what that means is that the patient has PSVT, which is normally a narrow regular tachycardia, but they also have a bundle branch block, which makes the rhythm look wide and regular. Now, if the R to R interval is irregular and a wide tachycardia, then we're thinking about ventricular fibrillation. This is wide, irregular, erratic, and it's very scary when you see it. Another possibility is torsades de pointes, and torsades is usually seen in a patient with preceding prolonged QT interval. A prolonged QT followed by a polymorphic ventricular tachycardia is highly suggestive of torsades. And if you zoom in, you see that twisting ribbon-like appearance, which is very classic. And the last differential rhythm is atrial fibrillation with aberrancy. AFib's normally narrow, irregular rhythm, but if you add the bundle branch block, it becomes wide and irregular, and I don't have a specific strip for it. So ventricular tachycardia that is not sustained, it is a diagnosis we often see providers reject, even when it's active. And I get it. There's some conditions like non-sustained VTAC, complete heart block, and chronic respiratory failure. It seems like they don't belong in the outpatient setting, but we actually do see patients in clinic with these diagnoses. Many patients with NSVT are actively managed in the outpatient setting with ICDs, antiarrhythmic medication, and ongoing cardiology follow-up. NSVT is reported using I-4720 ventricular tachycardia unspecified. So there's not a code that describes sustained or non-sustained, so you describe that distinction in your documentation. Okay, let's put it in practice with a case study. This is a 69-year-old male with ASHD, a previous STEMI 1 year ago, hypertension, hyperlipidemia, and non-sustained ventricular tachycardia. He's in for his routine 6-month follow-up. The AICD interrogation was reviewed, and it showed a few brief runs of NSVT. The longest lasted 40 seconds, and it was corrected with override pacing. No shocks were delivered, and he didn't have any associated near syncope or syncope. Recent blood work was reviewed, and his electrolytes are within normal limits. Guideline-directed medical therapy is optimized, and he's advised to continue daily aspirin, atorvastatin, metoprolol, lisinopril, and cardiology follow-up. And he's going to follow up in 6 months or earlier as needed. It may seem like it's not appropriate to include the diagnosis of NSVT in this visit since he's currently in a normal rhythm, he's asymptomatic. However, NSVT remains an active condition. It should be coded because it's being controlled by a device and medication. It's not resolved. So ask yourself, if we stop the medication or if the AICD were removed, would they possibly have an exacerbation? So the answer is yes. So the condition is considered active and it should be documented. So we use I-47 ventricular tachycardia unspecified, and we describe that distinction of non-sustained in our documentation. So next, let's look at a cardiology note. This is a patient having a pre-op exam. The assessment and plan include paroxysmal atrial fibrillation. She's tolerating Eliquis well and can hold it for 2 days prior to her surgery. The specialist also describes SSS for sick sinus syndrome, status post pacemaker, and describes the pacemaker interrogation. The 2 active cardiac arrhythmias here are paroxysmal atrial fibrillation and sick sinus syndrome. So even though her heart rate is 60, the SSS is still present and is a reportable chronic condition. Although the pacemaker is controlling the heart rate, it doesn't cure the sick sinus syndrome. It's still being managed and monitored. It's also important to note that you don't need to be the one treating a condition to document it and code it. You should still present all active chronic conditions, even if the specialist is managing the condition, because it still impacts your decision-making and it affects the patient's care. So to summarize, here's a few points to keep in mind for documentation. Document the clinical history, includes symptoms, timing, severity, potential underlying disease. Symptoms could be palpitations, dizziness, syncope. Include diagnostic studies. Many arrhythmias come and go, so single EKG might be normal. You have outpatient monitors, Holter monitors, event recorders, insertable loop recorders, and then there's the over-counter monitoring approaches, watches, and the Cardia Mobile or some. For patients identified with arrhythmias, think of several questions to answer. Which arrhythmia is present? Is it well tolerated? Does it require emergency care or a specialist? And should anticoagulation or other medicine be started? Document the diagnosis and use the most specific code possible. And finally, document the treatment plan. include medications, diagnostic orders, and any referrals to specialists or transfer to emergency department. So that's the more common arrhythmias we may see in primary care. It was lots of information, but as always, we'll give you a copy of the slides that usually have them by the end of the week. And you can also catch a replay of this session along with all of our other Lunch and Learn presentations anytime on our website at vaticahealth.com. We also have 3 live 1-hour seminars that were updated for 2026. They are approved for Category 1 CMEs, so keep an eye out for those. And so now we'll take questions, have a question and answer session. If you have any questions, put them in the chat. And if something comes to mind later, please don't hesitate to reach out to us by email at providereducationsupport@vaticahealth.com. We always appreciate the opportunity to support our providers, and thanks to everyone for joining us today. And I'll hang out here for a few minutes and see if anybody has any questions. I don't see any right now. And I'll give it another couple of minutes for questions. And if not, it's 12:25 Eastern, so I might get a few minutes back. Dr. Korn, I see your question. What will the impact of AI be on coding? So right now, I'm just going to take documentations relating to coding specific conditions. That is kind of outside of my area of expertise. It is massive impact. A lot of people are moving to it. I'm going to take that question back to Dr. Utash. We can always get back to you with that.
I can actually jump in. I'm on right now.
Oh, hey. You're here.
So there's a lot that's going to be happening with AI moving forward. We look at it as this, we keep saying this generic, AI, but there's a bunch of different forms, NLPs, LLMs, different neural nets, different ways that we're ultimately going to be able to, and when I say we, I mean the medical society collectively, not specifically Vatica and COSIVA. But ultimately, we're getting better and better at being able to recognize not only the diagnosis, but the surrounding scenario. Because the initial phases of AI, what we'd see is a ton of false negatives and false positives, right? It would see a diagnosis, it'd see surrounding information around it, but it wouldn't take into account another piece of information that would have been very significant, found somewhere else in the chart, that would ultimately cancel out the subsequent piece of information that it found later on. It's getting better and better at finding that and being more and more accurate. Again, we at Vatica, we have different algorithms we use in chart reviews to populate or tell our nurses of a possible or a probable diagnosis, and it's mainly based on claims data, frequency, recency, and specialist involvement in a diagnosis. so that we know where to look to find the surrounding information, but not necessarily suspecting new or unique conditions. On the Cosiva side, we do use an NLP that will do a first pass over the documentation by a provider on the data service. And that's used primarily for quality pickup, looking for different specified clinical indicators around different quality measures. We can also use it for coding. It's also then reviewed by a coder. So we do have products that are utilizing and leveraging different types of AI. And as it develops and as it becomes more accurate, it will be utilized more.
Thank you, Dr. Utash.
Yeah, absolutely.
We have a few more minutes if anyone has any other questions.
And I'll actually state one last thing. So we do a clinical validation, clinical review process at Vedika Health. So all the diagnoses that run through our system are clinically reviewed and manually reviewed by a person. That is a live person that is not leveraging AI or any other technologies like that as such. So just so we're clear on that.
Yeah, and they're clinical people.
Yes, they have nurse degrees and coding degrees. Absolutely.
Yeah. You're welcome, Dr. Korn. I'm glad Dr. Utash was here to answer that question for you. He said thank you.
Yeah, you're absolutely welcome.
Okay. If anybody thinks of questions later on, provider education support at vaticahealth.com is an email that comes directly to us, and we will always get back with you. And thank you so much for joining us today.